Hi everyone, Dr. Byron here, Clinical Director for Shape Primary Care Network and Clinical Lead for Barani Group Practices. Today I want to share with you some exciting work we've been doing in order to reduce the number of people in A&E and really understand why people attend A&E in the first place. Historically, nationally, as a primary care team, we've done lots of work to really reduce the number of patients having to attend A&E. Unfortunately, over time, the things that we've been doing have had limited effect. We've also made some big assumptions. We've assumed people attend A&E because they can't wait for their GP, or don't want to wait for their GP, or can't contact their GP. We've also assumed that people may attend A&E because they feel that A&E offers a more thorough clinical assessment than perhaps what's on offer in primary care. With the digital capabilities now available in primary care that weren't available before, I'm going to make a bold statement. It has never been easier than today to get access to a primary care clinician. Okay, so my journey started approximately a year or so ago when I was introduced to a powerful population clinical health digital analytics tool called Connected Care. Now, one of the things Connected Care had allowed me to do was to see in real time which of my patients were in the accident emergency department. It was amazing. So what did I do once I discovered this? Well, started a pilot. For me, it was really important and interesting to understand why my patients were attending A&E in the first place. Were they attending for clinically appropriate reasons or clinically inappropriate reasons? And if they were clinically inappropriate for accident and emergency, and perhaps could be dealt with and treated by myself in primary care, well, why can't I do that? And that's exactly what I did over 2.5 weeks. I pulled out 16% of patients back into general practice. And I did this when there were clinically inappropriate attendances to A&E, and the patient was comfortable and felt safe to come and see me almost immediately, rather than wait approximately 4 hours and more to be seen by an A&E clinician. I worked out that 60% of my patients had attended A&E for clinically appropriate reasons, and about 28 to 30% of patients were clinically inappropriate. I also worked out that 8% of the patients in the A&E department were there because my team or primary care teams had referred them to the accident and emergency department. Remember, this was just me, a single GP, doing this between his own patients. I also had some limited information. I knew which of my patients were in the A&E department, but I didn't necessarily know why they were there. And as I did this more often, I started to use other tools like the hospital clinical system. Okay, so after the initial pilot, I was excited. I wanted to share with anyone and everyone who would listen my findings, what I've done, but more importantly, the potential to scale this project up across multiple practices to help multiple patients and perhaps multiple A&E departments. I was invited, and I was fortunate enough and lucky enough to be invited to various clinical forums and meetings to share my findings. We managed to scale this project up across the whole of Slough with a makeup of 16 practices with a combined list size of 160,000 registered patients. So now the project was greenlit, I had some work to do. The first thing I did was go back to my initial pilot and reflect upon some of the learnings and things that I'd done. And I used this to create a clinical SOP, a SOP, which could be used by any practice who wanted to participate in the project moving forward. I then worked with our clinical support unit locally to develop an easily importable EMIS template. I then worked with the Connected Care team to make some changes to the A&E TC notification dashboard. I thought it would be a bit more efficient and better if we could have some more information. So now the dashboard not only shows which of my patients are in the A&E department, allowing me to identify them, but it also shows me what their presenting complaint is. And lastly, what we have now is each patient stratified or segmented into a clinical criteria, essentially red, yellow, or green. Armed with a clinical SOP, a new EMIS template, and a new and improved A&E TC notification dashboard on Connected Care, I approached my fellow 16 practices in Slough in order to scale the project up. The response was overwhelmingly positive, and almost immediately every practice signed up to participate. So where are we right now? As of 16th of January 2023, 13 out of 16 practices across 4 PCNs are actively reviewing their patients in the A&E department in real time. We've managed collectively to review 634 patients. We've worked out that 15% of these patients are attending the A&E department for clinically inappropriate reasons. And over 90% of these patients have been sent an educational text message that helps them understand what to do and where to go if requiring medical assistance. Now, of those patients who are attending for clinically inappropriate reasons, we've managed to pull back and pull out 42% of these patients in real time out of the A&E department back into primary care, therefore reducing the number of patients that the A&E teams have to see. When I look back over the project and the pilots over the last few months, really the thing that comes to mind is the passion, the enthusiasm, the positivity and support that each practice in Slough gave to the project. Now, it's early days, but the project so far has shown to be effective, cost-effective and sustainable. It builds upon and strengthens the rapport between primary care and patient. And it draws upon one of the most magical components which is underrated in the NHS. And that's the concept of continuity of care, which is the big driver behind this. For those of you who are watching, I encourage you to stay with us as we continue on this journey. Thank you for listening.